Good afternoon. I'm Basil McFadden, and my presentation today will be on adenosine deaminase deficiency, and I will be exploring an alternative approach. Now, before we start the presentation today, I wanted to give you a little background as to the reason why I chose ADA deficiency. Now, I don't know anyone with ADA deficiency, and I didn't even know what ADA deficiency was. So that was my reasoning as to why I chose this topic. It's because it piqued my curiosity, and as an inspiring scientist, I want to learn things. I want to learn new things, and hopefully it can help me find a cure for these things one day when I become a doctor. So we're going to get into our presentation. So what is ADA? What is adenosine deaminase? Essentially, it's an enzyme that's involved in purine metabolism. It's needed to break down the adenosine in food. That's what deaminase means. It means to break down deaminase, or break down adenosine, excuse me. So it's present in practically all mammalian cells. It's also found in bacteria, plants, invertebrates, and vertebrates as well. So, what is ADA's primary function in humans? How is it important to us? And why is it so important to us? So if we were to look at this picture, it would give you the answer. Essentially, its main purpose is to help develop and maintain our immune system function. So, what is the deficiency? What makes us ADA deficient, or what makes a patient who has ADA deficiency deficient? Well, number one thing is it's an autosomal recessive mutation that causes the ADA gene to not be expressed. It will most likely lead to severe combined immunodeficiency within 6 months of life. So when a child is born and they have ADA deficiency, within 6 months they'll have SCID. Another caveat to that, as we talked to earlier, people with ADA deficiency, they can't break down adenosine, and that will cause something called adenosine toxicity. Now, adenosine toxicity is what would cause us to have immunodeficiency. So they go hand in hand. So individuals with SCID virtually lack all immune protection from any and all infections, bacterial, viral, fungal, just to name a few. People with ADA deficiency are susceptible to repeated infections that can be extremely fatal to them. And also, the lymphocyte count, excuse me, let me go back for a second. The lymphocyte count is 500 per microliter. Alright, so what are the associated diseases and disorders? If you look at this picture, this is a picture of an infant with a severe rash that stems from the ADA deficiency. So, one of the first most common diseases that's associated with ADA deficiency is pneumonia. The second one is chronic diarrhea. The third one is skin rashes as shown in this picture right here. Pulmonary inflammation, thymic cell death or T cell death, and defective T cell receptor signal. So what are the management options? How do doctors manage or treat individuals with ADA deficiency? So there are two management pathways. The first management pathway is to treat the associated infections as they arise. So if someone someone with ADA deficiency acquires pneumonia, you would treat the pneumonia. Or if they acquired an ear infection, you would treat the ear infection, or viral infection, they would treat that. They would treat any infection that they acquire as it arises. So the second treatment is the prevention. They prevent the manifestations of any and all acquired infections, and the purpose of it is to promote and maintain and restore optimal immune system function. Now, there are 3 ways that you can do this. The first way is through a bone marrow transplant or stem cell transplant. The second one is the enzyme replacement therapy with a polyethylene glycol bovine ADA. And what that means is that they get an ADA enzyme from a cow or bovine cell, and they synthesize it, put it into a syringe, and they give it to the patient through injections. Most patients that receive ERT or enzyme replacement therapy, they get it about weekly to bi-weekly. Just take a step back, people with bone marrow who get bone marrow transplants with ADA deficiency normally don't need to go through that much treatment. It's normally one transplant, and then they wait a couple of years, maybe about 3 to 5 years, and they get another transplant. So the issue with that is you have to always find a donor. And in certain cases, they can use a non-ideal donor for a bone marrow transplant. And you can kind of see the issues with that. And to take a step forward, to go into the last treatment option is the gene therapy. Now, gene therapy seems to be pretty promising right now, but it's currently experimental. In the world right now, there are about 12 sites that actually are doing studies or actually doing gene therapy right now. So you can see that it hasn't really progressed to whether they know whether this is going to be the definitive response or the definitive treatment option for patients with ADA. But in time, we will see. So here are some statistics that are associated with ADA deficiency. It occurs in about 1 in 200,000 to 1 million. So if we were to extrapolate these numbers, there are about 4,000 to 5,000 infants in the world that have ADA deficiency or born with ADA deficiency if we were to take these numbers and extrapolate them worldwide. So about 10 to 15% of the ADA deficient cases have a delayed immune deficiency response from 6 to 24 months to adulthood. Now, the 6 to 24 month time range, that's referred to as the delayed onset ADA deficiency, and the one in the adulthood is called the late. Now, people who acquire ADA deficiency, or if the deficiency arises in adulthood, it normally arises between the ages of 20 and 40. So there's about a 20-year range in which individuals can find out whether they are susceptible or whether they have ADA deficiency. Now, people in these cases who have the late onset or the delayed onset, they tend to have a less severe immunodeficiency response. Like they're more tended to get the less severe infections like ear infections and fevers. They don't normally get the SCID that's associated with ADA deficiency. So, talk about SCID. About 15% of the SCID cases in the world stem from ADA deficiency. 100% of infants that have ADA deficiency will die within 1 year if they're left untreated. So, what's the million-dollar question? After looking up all of the associated articles and looking at numerous websites pertaining to ADA deficiency, what was the million-dollar question? What question did I ask myself? And simply what I asked myself was there any alternative treatment options that were just as effective, if not better, than the 3 ones that we talked about earlier, or the 4 ones we talked about earlier? You know, would these alternative approaches be less cost effective? Would they even be better for the patient as far as a holistic approach, a natural approach, instead of waiting for a donor or getting an enzyme from a cow or taking some experimental treatment to treat this disease? So I did a lot of research and I tried to find many things that answered my question. And unfortunately, I didn't find any definitive information that states that there is any alternative treatment options to ADA deficiency rather than what we've talked about earlier. Now, I think through time and as science progresses and the science of genetics progresses and the science of medicine progresses, we may very well find a better treatment option than the 3 or 4 that we talked about earlier. I think the reason why there really isn't a lot of alternative approaches or a lot of studies that talk about alternative approaches is because it's such a severe or such a rare disorder like we talked about earlier. If we were to extrapolate those numbers,
about 4,000 to 5,000 people in the world would have this disease or have this disorder. So, due to the rarity of the disorder, it would be the reason as to why there aren't any definitive research, any definitive research that states that there is any alternative treatment options for the disease. So, like I said, in time, hopefully we can find some. So here are some references that I cited. In the world right now, the number one researcher in regards to ADA deficiency and SCID is Dr. H. Bobby Gasper. He is probably the number one researcher. He's probably the number one person that I found, whose name I found in regards to ADA deficiency. So if you wanted to acquire or wanted to find out more about ADA deficiency, you can just Google his name and see what other things he's done in regards to ADA deficiency. Now, I'm Basil McFadden. This has been my presentation on ADA deficiency. Thank you.